Hey everybody, welcome to our discussion on growth and development. Grasping understanding about growth and development is essential for the nurse when caring for children and families because it forms a foundation for nursing and medical care. It also allows for identification of essential growth and development milestones, as well as provides an avenue to connect with our clients, regardless of age, through both play and cognitive development. In this unit, we will examine factors that influence growth and development. In addition to that, we want to look at various physical and psychosocial milestones across the lifespan of a child. Be sure to be attentive to the differences and similarities noticed amongst all age groups because they will be integrated in everything that nurses do. If we each take a moment and reflect, I bet we'd find that we have an age group that we really enjoy interacting with when we have the opportunity. You know, that age group that you really just connect with. Did you ever consider why that might be? Is it their cute little personality, or maybe it's because they like the same activities as you do and it may come easy for you to connect in that way. If you like to color, you can connect with that age group that really likes to color. Or if you're a Star Wars fan, maybe you like that school age group that loves to play with those action figures. Or maybe you like that age group because they can carry on a conversation with you. Or maybe it is just that they are so adorable. Or maybe not. This is one of my favorite Seinfeld episodes. I particularly like Kramer's reaction to that beautiful baby boy. Oh my goodness. But we have to get back to the lecture. So, when we reflect on growth and development, theorists commonly divide the lifespan into 5 categories. These categories are pretty typical as we think across a lifespan. You have infant, toddler, preschool, school age, and adolescent. We will be using these categories throughout this course to personalize nursing care to those children in a way that they will relate to and connect with whatever is going on. These are 2 of my children. Keaton is 4 and Emmylise is 9. So according to our categories in the previous slide, Keaton would be in preschool and Emmylise is in the school age category. Would you agree that nursing care is different between these 2 children? Sure, we may do some of the same things, but the way that we approach the care is going to be different. I can assure you that in my experience, it most definitely is the case. Emmylise is a typical 9-year-old girl. You know, the 9-year-old motto, don't let them see you sweat, and let me tell you everything I know about this. She's very inquisitive, but peer influence is starting to have an impact on her life. She likes to be in charge when she can and answer questions about what she knows about what is going on. For example, I can take her to the doctor and probably won't even need to go back with her. She can tell the doctor exactly what is bothering her. Even when she feels scared, she can hide it from others. You see, she has food allergies and has to carry an EpiPen. When we were going through the process of finding out what her allergies were, we had to complete a series of tests. She was scared, but was Miss Maturity when talking with the staff, and held it together until those last few scratches. Afterwards, she found herself a bit embarrassed because she cried. Remember that peer influence? But quickly felt better after a little reassurance from the nurse and a reward from the treasure chest for such a good job. When you have to get a 116 scratches, you should earn something, and she did. Let's just say Mom might have gotten her an extra scoop of ice cream after we finished. The staff also was able to teach her how to use her own EpiPen and use her inhaler. She could do it and be responsible to play a part in her care. Keaton, on the other hand, is a very active boy who loves mommy time. He's not so sure about doctors, but he sure loves to play. He broke his heel this past spring. We knew something was wrong because he wouldn't play, and he just wanted to sit on the couch and have things brought to him. But if he wasn't on the couch, he crawled everywhere and wouldn't bear weight on his foot. At the evaluation with the physician, he wasn't much for chatting like his sister might be, but he was very interested in playing ball and coloring on exam room paper with his new crayons. He also spent the entire visit on my lap and would not go to X-ray by himself. He loved the stickers he earned for a reward and made his bones smile for his doctor. However, unlike my daughter, Keaton didn't understand or follow the discharge instructions given. He was placed in a boot, and I was asked to put him on limited activity. A 4-year-old on limited activity. It worked for about 2 days, and then as he started to feel better, he came back around to his normal growth and developmental milestones. You see, rather than teaching Keaton about his boot, I, as his mom, had to learn to care for him during this time. As nurses, we can and should use each child's growth and development milestones to help us personalize that care, meet that child's needs, and integrate principles to relate both to the parent and the child. Kids come in all shapes and sizes, as well as cognitive abilities. This is Haley. She's 13 years old, and her growth classification is an adolescent. If you talk to her mom, she'll tell you that most definitely she has her teenage moments. She can be sassy or even get embarrassed when mom takes too many photos or something along those lines. She also loves her friends. However, Haley's cognitive development is much different, and her growth, her cognitive development is much different than her growth development. She was born prematurely and spent 93 days at Riley in the NICU. She has cerebral palsy and seizures caused by a brain bleed after birth. She's unable to walk, she rides to school in a wheelchair, and she's unable to use her left side to its fullest potential. I bring her example before you to show you how growth and development influences care. Our approach to her care is very different. Even though she's 13, she couldn't be responsible for her own care, and her mom must be totally involved. But as the nurse, we will still integrate adolescence into our conversation. I may not talk to her as if she's a child, or choose clothing that would fit her being a child. Parental education about puberty changes and menstruation, and an encouragement to social interaction is certainly going to be something that we discuss with mom and integrate into her care. Although there are gaps in her growth and development timeline, they can be made somewhat smaller through the integration of various resources in her community. Collaborative care integration is a great use of growth and development principles because needs can be identified and met to help her to have the fullest potential she can and to thrive in her environment. Through rehabilitative services, I have seen Haley experience an increased use of that left side, and she can now even say a few words. Had growth and development milestones never been addressed with her, we may have had a very different story. So what exactly is growth? Well, growth is defined as an increase in something. In childhood growth, we see an increase in the number of and maturation of cells. For example, kidney function increases with the age of the child. This means that a child who is 2 months old cannot tolerate as much fluid as a child who is 2 years old. This impacts our nursing care because it might mean that we have to control the rate of IV fluids. We might have to check frequently for excretion in regards to wet diapers. And we might see orders that state things like wait until after the first void to start adding fluids with electrolytes. We see antibiotics delivered in syringes rather than piggyback fluids, and this is set because it helps prevent fluid overload in a still maturing system. Growth also encompasses lengthening and strengthening of both bones and muscles, resulting in changes in height and strength. Not only does this mean frequent clothes shopping and entry pantries, especially with those boys, but nursing care, it is important that height and weight are measured at yearly intervals, and that nurses are identifying any change in normal growth rate and examining the reasoning behind any changes they see. We'll talk more about well screenings in our next lesson, but looking for trends is important. A stable or an increase is the goal in most cases. Growth charts are often used to create a visual graphing trend for quick identification of changes. A decline may indicate that something's going on and throw up a red flag for letting you know that potentially other needs might not be met. You can then let your physician or provider know and collaboratively work together to resume a goal of stability or increase in that milestone. Children are unique. Everybody grows at a different rate regardless of their age. I mean, look around any preschool class and you'll see tall kids, shorter kids, kids with long legs, kids with short legs, kids who've lost teeth, kids who haven't lost any teeth. All of these changes occur at different rates regardless of their age. Therefore, we use categories of classification rather than age group to provide a broader range for milestone achievement. In other words, a child in the school age category would be ages 6 to 12. All across that lifespan they have to achieve those milestones. Even though growth rates vary, we know that all development occurs in a distinct pattern across the lifespan. You see, growth occurs in two directions. It occurs cephalocaudal and proximodistal. In other words, children grow from the head downward and then from the central outward. To put it in real example, let's take gross motor development. A child must first master head control. Once head control is mastered, they progress to sitting. Once they sit, then they can stand. Once they can stand, they can either crawl or walk. You see, each task requires more control of muscles until they finally begin to control these actions in a new way, such as control of the arms, trunks, fingers, and eventually they can control these to participate in things like sports or other types of physical activities. It's important, though, to understand this principle because if things aren't progressing as needed, for example, if a child is having difficulty to mastering head control, we need to intervene so that they can master that goal and progress to the next. Development, on the other hand, is just a little more broad, and we tend to think of development in the physical realm as well as the cognitive realm. As the child ages, they progress from a lower functioning individual to a higher functioning individual in both physical abilities and cognitive development. For example, an infant has very little physical development when they first arrive on the planet. Basic functions are all that newborn has. You see, it's a starting point for sure. Newborns are a bit floppy and they can't seem to figure out what to do with these hands and legs and that they haven't really had to use before now. They tend to communicate just by crying and they require being carried everywhere. Now compare that to a toddler. Toddlers can stand and even run. They have both fine and gross motor development as they can pick up crayons, they can ride something that they could sit on, and they could push something with their legs, and they can even walk independently. They're also very good at telling you what they want, or in most cases, what they don't want, and have an ever-growing vocabulary. Development is looked at under the lens of two major theorists, Erikson and Piaget. Piaget focuses on learning or cognitive development, whereas Erikson focuses on psychosocial development. These will be discussed in a little more detail towards the end of our lecture. As with growth, developmental progression is monitored during various intervals in a child's well care. There are a variety of screening tools that are useful in helping healthcare staff in this task. The first type of developmental screening tool that we tend to think about is the Denver 2 developmental screening tool. What the Denver 2 allows a parent to do or allows staff to do is that they can take inventory of the motor skills that their child has mastered compared to those they have yet to achieve. Usually, like I said, this is completed at a well check, and the answers are reviewed by the provider, and they uses that data to make important referrals to assist with this motor development. I think it's also helpful as a new nurse to take a look at something like the Denver 2 because it can help you interact with your child. In other words, you might find a new way to connect with your patient. Old MacDonald is a great way to build rapport with a little one who has just learned to identify animals and their sounds. If you look on the next slide, there's an example of the Denver developmental screening. The ASQ3, or Age and Skills Questionnaire, is another form used in pediatric care to monitor developmental progress. Some of you have probably even seen something like this when you've gone to a well check with your own children. It's sometimes preferred over the Denver 2 because it has a specific category where it addresses communication and language development. In situations where this might be helpful would be a child who is having difficulty with language development. You've got the data to support he's not meeting those milestones. You can see where the deficits are at. Maybe he's has a small vocabulary or having a problem with intonation and intelligibility of that speech. This helps gear the referral to something that would help that language development. It might be a simple fix, such as, let's try reading to your child every night for a month and see if something helps. Or we may need to get something a bit more invasive and make a referral to speech therapy. Whatever the need, the tools shown, both the Denver 2 and the ASQ, are helpful in finding that need and then plugging the family into places that can help the child progress and be successful in their environment. Maturity is that final piece of the puzzle when we look at growth and development. It's often referred to when we're looking at things like organ development in each body system. We might say these organs have reached the mature age where they can receive things, receive doses, receive fluid volumes as that of an adult. We also look at it under the lens of organ development when we look at things like sexual maturity and Tanner staging, when we look at school-age children and adolescent children. However, a more universal application can also be looked at when we're thinking cognitively and responsibility. See, it's more of a qualitative focus. As you grow, you become more mature in the things that you can do, the conversations that you can conduct, the problems that you can solve, and the ability to care for yourself independently. Maturity is viewed as, like I said, a qualitative change. Children become more independent, they adapt to change, demonstrate competence and ability, and really begin to care about the details of their health after a certain age. Maturity allows them to be responsible for things that might prepare them for adulthood. An example of maturity in this realm might be when you have a 17-year-old boy that has shown responsibility and is allowed to have his driver's license and then obtain his first job. He must take responsibility of the job and seize opportunities to make good choices that prepare him for the next phase of life. On the other hand, a parent may choose not to allow a child to have a driver's license or job before a certain age because he or she is not demonstrating responsibility or maturity in his decision at home. So maturity can be looked, though it's qualitative in nature, it's looked at not only in the realm of are they adaptable and competent to change, but also what are they doing cognitively and mentally. So it really should come as no surprise to know that there are certainly factors that can either inspire or delay the progression of growth and development in any child. The most common factors that we look at as far as an influence on this is hereditary, environment, culture, nutrition and health status, and family. 4 of these are modifiable risk factors. But unfortunately, hereditary factors can be managed, but they cannot be eliminated. But if we can identify risk factors, we can implement a plan to work with the parent, family, or child to do the best they can with them and maybe even eliminate the risk factor. The result is that they may be able to achieve milestones. Let me give you an example. This happened to me when I was practicing at the Proton Center and I cared for a little guy named Carter. You see, Carter had a benign brain tumor that was causing all kinds of problems for him. He was overweight due to sodium and fluid retention secondary to his tumor. He was unable to ambulate due to his size because of steroid and edema. Okay. He was also unable to eat and communicate properly. I could still hear him say, "I'm hungry." His tumor was so large that his right side of his brain wouldn't talk to the left side of his brain. But you know what? Before all of this happened, Carter was a normal child. And the more you got to know him, the more that you could tell that there was just a 5-year-old little boy just waiting to come out and play. Once he finished his treatments, he started to follow up with the clinic on a biannual basis. So during his first visit to the clinic, it was time for him to come back, and he pushed himself down the hall in a wheelchair. By the second follow-up visit, which would have been 1 year after his treatment, he was using a walker to ambulate. The third visit, here comes this 5-year-old boy who was normal size of a 5-year-old boy running down the hallway. All I could think when I saw that was, look out, kindergarten, here comes Carter. This little boy was back, he was thriving. You see, because his health status and nutrition were not well, his growth and development were halted. And in some ways, he had regressed, gone backwards to previous states. One of those factors were eliminated. Some of those were eliminated with time and healing and medical intervention to return things to normal or to return to balance. Because of that, Carter was able to catch up and thrive, and to my knowledge is still doing very well to this day. Wow, we have covered a lot so far. I think you've earned a brain break. I am truly impressed with kids these days, let me just say. Before we know it, I think they might be texting us from the womb. Our learning activity this week will be focused on growth and development progression. I'm going to ask that you review the next several slides, through slide 46 to be exact, and use the information on the PowerPoint slides to complete your growth and development table. I think that will help to minimize the discussion and the audio on the remaining parts of this PowerPoint, but please be prepared through completion of that table to work in groups and apply this knowledge in clinical practice. So why is it important that we understand growth and development principles? They really play an integral part in nursing care. Everything we do, these principles are foundational to pediatric care. You see, we give weight-based dosage until the child is adolescent. Then they graduate to adult dosages. We learn to play with a toddler while giving medications, and even arrange for tutoring and social visits while school-age children are hospitalized to facilitate both psychosocial and physical healing. You see, integrations are numerous and have numerous applications, many, many more than we have class time to discuss. But it's going to be important for you to understand how to integrate growth and development into nursing care. Your textbook summarizes examples at the end of each age group to help you to apply growth and development to nursing practices. It'll be important for you to review these examples in your textbook and let me know if you have any questions. Before we conclude our lecture on growth and development, let's stop just a minute and talk about play. You know, play is a very big part of what kids do. So if that's what we're doing, we should be able to go right along with them and integrate it into taking care of the child in whatever environment they are in. You see, some people would say that kids play to learn. I think that statement is very true. I mean, think about preschool. We sing the ABC. We learn the ABCs by singing a song. We may learn to write our names by making shapes of letters with Play-Doh. Depending on the age of group and the type of play that they are drawn to, we can say that we can also use this in nursing care. As children grow, the play becomes more collaborative and more complex. Children go from playing without a purpose at all, I mean they're just kind of playing reflexively, to having a purpose when they play with those blocks in building or constructing a tower. They go from observing kids playing and just watching to playing with others, and then taking what they've learned in playing with others and focusing it in an organized way, governed by rules and roles, such as playing on a baseball team. Each area of play supports the growth and development that child is at, and it also can help support our assessment data. The other thing that play is very big on is it helps us to implement principles of atraumatic care and communicate with our child. We talked extensively, or a little bit in the last lecture, about atraumatic care. Play is the foundation of that. Remember the video of the doctor giving the shots? That shows the progression of play that would work very well with that age group. You can see how a game or something like that might not be as effective on an adolescent child versus someone of that proper age. The next few slides review play and the progression of play in our world. Hang in there, guys. We're almost done. There are two developmental theorists that frame the care of the pediatric client, Erik Erikson and Jean Piaget. Their work has impacted pediatric care and patient education for many years. Erikson's theory focuses on psychological development and its progression based on conflicts faced by each age group. Its complexity increases as the person ages, and it becomes essential to resolve conflicts within each group before they can progress to the next group. The other part of his theory includes the development of essential virtues, the solidifying of essential relationships, and the age-old question that frames each stage. I'd ask for you to review the next few slides and focus on each stage. Make sure you understand the features of each stage of Erikson's development. I think it's easiest to view and discuss this in table format, so I'm going to let you review the individual slides, and I'm going to skip to slide 59 for the rest of the discussion on Erikson's theory. but make sure you go back and review each phase. Erickson's theory can be applied to nursing care. Let's pretend that we're caring for a 3-year-old child. We know, based on Erickson's theory, that they really kind of like their independence. I want to do it. We can use this to our advantage. Let's say we have to do a dressing change. Why not allow the child to help us? We can allow them to choose their bandage. We could allow them to put the final piece of tape on our dressing. We could allow them to hold the gauze in place if appropriate. You see, we're giving the child a simple job to do. They in turn will feel value and gain confidence and independence as they desire. By allowing them to choose the Band-Aid and place it themselves, they can even put their own flair or style to it and place it anywhere and any way they want. You see, we're enforcing the answer to the question that they're asking, which is it okay to be me? Sure, it's okay to be you. You can put that Band-Aid on any way you want. Another example might be during adolescence. They are all about identity. I read recently an article and watched a video about a company that makes hospital gowns for kids that are in the that look like regular clothes. The child is able to choose something that fits their personality so that they can wear it during their time on the unit. You've got to take a moment and check out the video on the next slides. It's Erickson's theory at work. The next 4 or 5 slides summarize Piaget's cognitive development theory. This theory forms the basis of all patient education. In other words, it's foundational because it helps us understand what does the patient understand, when can they understand it, and why. Do they have that cognitive ability to understand why? I'd ask that you review the next few slides as it separates the contents of Piaget's theory. But I'm going to go ahead and jump ahead again to the table that kind of pushes it all together because I think it simplifies the content and makes a better talking point. In Piaget's cognitive development theory, cognitive development progresses from a sensory motor to formal operational. And this occurs over the span of about 11 or 12 years. We talked in our last lecture that cognitive development impacts care because the child can begin to think logically about events. You see, abstract thinking develops around age 11, and clients can make the decision and even think through hypothetical situations. Think about how this might be integrated into your nursing care. The example I could think of was when thinking about a 3-year-old with a broken arm. You see, 3-year-olds are very literal, and they don't always know the meanings of the words that they are saying or we are using. Simple things like broken bones might be very hard for this child to grasp, because that arm is still there. How can it be broken? My son's preschool teacher recently broke her arm, and a classmate was really quick to tell me that she was okay because her arm didn't break off, and that was a good thing. I thought it was so cute, but kids are very literal. So what do we do with a broken toy? If something breaks, we throw it away, or we try to glue it and fix it. That child was just happy that Mrs. Paget would come back in all one piece. But as they get older, they understand the concepts better and better, because they understand that a bone is there regardless of change. Nurses also need to use cognitive development, but they have to be careful when they relate medical care to people. Think about going to sleep. You just never know what life experiences kids bring in with them. If I told someone who was going to receive anesthesia that we were going to put them to sleep, it could easily be mixed up with what they had to do to their family dog last month. That dog was put to sleep and he never came back home. Be aware and consider both what you are saying, how it can be said, and make sure that patients are walking away with a clear idea, no matter how small. As we conclude, I'll leave you with a question. How do you see these theories of Erikson and Piaget, as well as others you have studied but we didn't lecture about, Freud and Kohlberg? How do they impact nursing care? I would recommend that you take a look at Kohlberg's theory in your NCLEX review or ATI to review Kohlberg's theory of moral development. And then Freud, a nice review would be from Concepts with Mental Health, and his development is related to sexual development. Table 31.4 in your text does a great job helping you see the application of all these four theorists and all the ways that they can impact nursing care. Thank you guys for taking the time to listen. Take a few minutes after you're done with this lecture and jot down any questions that you might have. Bring them to class with you and we'll get everything clarified. Hope to see you guys soon.